Okay, good evening, everyone. Thank you again for being here. It's very busy here. It's great to see that, and also welcome for those of us that join online. Today we're going to hear about a topic that is the aging mind. My name is Annemieke Verhorst, and I'm the Associate Vice President Research here at the University of Manitoba. I would like to begin by acknowledging that the University of Manitoba campuses are located on original lands of Anishinaabeg, Inanuak, and Sininnuak, Dakota Oyate, and Dene, and on the national homeland of the Red River Métis. And earlier this month, the University of Manitoba launched the Truth and Reconciliation Framework, Time for Action. And I'm very proud to be associated with the university community that is advancing truth and reconciliation and fosters relationships in a respectful way with First Nations, Inuit, and Métis communities. Thank you for joining us here today in person and online. As I said, the topic is the aging mind. And the Knowledge Exchange is a very important event because it allows researchers to share their knowledge and latest findings with the general public. And the Knowledge Exchange is a collaboration between the Vice President Office of Research and International and the U of M Learning for Life Network. This evening, we will learn about conditions and factors that can influence the risk of age-related conditions such as Alzheimer's and dementias. We will also learn about new research for the diagnosis and the treatment of conditions related to the aging mind. This topic is of critical importance, and a small fact that I learned today is that 20% of the Canadians are actually 65 years of age and over, and this number is only increasing this decade. Our moderator this evening is Michelle Porter, and Michelle is a professor in the Faculty of Kinesiology and Recreation Management. Hello, Michelle, very nice to see you again. And Dr. Porter is also the director of the Center on Aging. And through its activities, this center has made an enormous positive impact on Manitobans and Canadians in general. Dr. Porter is a leader in the International Age-Friendly University movement. In fact, she led the University of Manitoba to become the first age-friendly university in Canada. Thank you, Michelle, for that. That's wonderful. Thank you. Dr. Porter has held influential executive positions, for example, with the Transportation Options Network for Senior here in Manitoba, as well as with the Active Aging Canada. So thank you very much, Michelle, for everything you do. I really appreciate that. I'm passing it on to you now. Thank you very much. Miigwech and merci.
Thank you very much for the introduction, Dr. Verhorst, and your kind words. It's a pleasure to act as the moderator for this interesting event and on this particular topic. Throughout my career, I've learned that people's fears of aging are often connected to their fears about diminished cognition and a stereotypical view that aging is universally associated with diminished abilities. While diseases of the brain are very real and affect large numbers of older people, by no means is dementia inevitable for all. Over my career in attending gerontology conferences, there have been some big changes in this field, but unfortunately also some recurring challenges. Although we now fortunately think in terms of preventing or delaying conditions like Alzheimer's, there is still a huge amount of controversy about what actually causes it, and therefore we seemingly remain far from having a cure. So I would like to now turn to providing an overview of how we plan to proceed with this hybrid event presentation format. Each Each of our panelists will briefly discuss their perspective on tonight's topic for discussion, and then I will open things up for discussion. The microphone is going to be brought around for questions for the in-person audience, and Dr. Fahrenhorst is going to be doing that. And then live stream viewers can submit their questions via email at the address that appears on the screen and in the YouTube description below. So this brings me to introducing tonight's expert panel, all of whom are associated with the University of Manitoba. Starting us off will be Dr. Corey Mackenzie, a professor in the Department of Psychology and the Faculty of Arts. Dr. Mackenzie is also a research affiliate of the Centre on Aging. Next will be Dr. Ji-Yoon Ko, who is a Canada Research Chair in Neuroimaging and Neuromodulation and Associate Professor in Human Anatomy and Cell Science in the Rady Faculty of Health Sciences. And our last panelist is Dr. Phil St. John, Professor of Geriatric Medicine in the Department of Internal Medicine at the Rady Faculty of Health Sciences, and he is the Manitoba site co-lead for the Canadian Longitudinal Study on Aging. And Dr. St. John is also a research affiliate of the Centre on Aging. Okay, we're going to start off then with Dr. Mackenzie and his remarks.
Good evening, everyone. It's really nice to see lots of hopefully friendly faces in the audience tonight. It's my pleasure to start this discussion off on a positive note. We're going to be talking about things like Alzheimer's disease and dementias that are sort of challenging. But when I was asked to think about changes in the mind with age, what I wanted to kind of raise as my first point of discussion has to do with how mental health, if we think of mental health broadly in terms of things like anxiety and depression when it's not working well, or in terms of happiness and well-being when it is working well, like how does that change across the adult lifespan? And the good news is that it tends to improve with age. We know this at least from middle age. There's really good evidence that from middle age, let's say age 50 or so on into later life, that rates of depression and anxiety, substance problems decrease, rates of happiness, well-being, positive affect, those things increase. That's not universally true, but that's true on average, and we know that from really good population level data. So that's my first sort of point that I want to raise, is that most of us, if we live long enough, can expect to see improvements in mental health into late life. Now, the second point I wanted to raise is a question of like, well, why is that true? So why is it that mental health tends to improve as we get older? And here I like to talk about a couple of theories. One is a theory by Susan Carstensen at Stanford University. So she has what's referred to as a socio-emotional selectivity theory. It's a mouthful, but really what it refers to is the fact that when we're young, we tend to have goals that focus on kind of expanding our horizons, learning new things, having 600 Facebook friends. And as we get older and as we perceive time in our lives as running out, it's that perception of shrinking time horizons that tends to allow us to shift our goals away from expanding horizons towards emotionally meaningful experiences in our lives. So for most of us, that refers to spending time with people that we love and that we care for and that who love and care for us. So as we get older, but this is also true for younger people who experience their time horizons shrinking due to things like terminal illness, for example, that tends to shift our emotional experiences in positive directions. I did want to mention one of Carstensen's former students, Susan Turk-Charles. She took her theory and expanded it into something called strength and vulnerability integration theory. So she acknowledged the socio-emotional strengths of aging, but she also acknowledged that there are, in fact, vulnerabilities that happen in terms of mental health as we get older. So those are things like chronic illness or caregiving for an older adult with dementia. Chronic forms of stress can reverse those age-related improvements in mental health and cause mental health challenges and struggles for people that we'll talk about tonight. So that was my second point, was first one, mental health improves. Second point is we know we have some reasons why we think that's the case. My third point has to do with interventions to treat or prevent dementia such as Alzheimer's disease. And I wanted to focus, because I'm a clinical psychologist, on lifestyle interventions. And there are drugs. We'll talk about some of the sort of new things that are happening, exciting things that are happening. But there is really, in my opinion, some pretty exciting evidence that lifestyle interventions are showing to be quite effective in terms of either preventing dementia or reversing it in some cases. So this is, what are lifestyle interventions? They are interventions that point to sort of 5 key sort of factors that you want to target in these interventions. Those are diet, exercise, sleep, stress management, and attending to your social network, your social supports. So interventions that attend to those factors and get people to eat healthier diets and to sleep better and to exercise more, get more social, manage their stress. Those things are having significant, really impressive impacts on cognition, including in people with mild cognitive impairment and dementia. So that's my my introductory sort of remarks about this. I'll pass the baton.
Okay, great. Thank you, Dr. Ko.
Hi, I'm very pleased to be here. So I just want to elaborate more on the Alzheimer's disease because that's my research interest. So Alzheimer's disease is very common, like 1 in 9 people with the age of 65 years old have Alzheimer's disease. So virtually everyone is affected by this disease indirectly or directly. Traditionally, Alzheimer's disease is regarded as a disease that can affect anyone, and there's nothing really that you can do except for those lifestyle, no clinical intervention was possible. Now, this has been changed recently. So in the past 2 years, FDA approved already 2 different kinds of treatment that can slow down the disease progression. So how it works is that it binds to this beta amyloid, which is an abnormal protein that is thought to be cause the neurodegeneration. So it tags the beta amyloid, and your immune system will clear them out. So that's how it is going to slow the disease progression. And then this drug, there are 2 different treatments that has been approved by FDA, and it has been approved in Europe, and Japan, China, South Korea. Canada is still reviewing it. It is another. We need another day to discuss why it is still reviewing it, but it will. I mean, based on what has. On the countries that there are so many countries that have already approved, I think the change is imminent. So it is going to come soon. And the problem here is that the treatment is not like a magic bullet. It comes with a lot of side effects. So it has intracranial bleeding, brain swelling, and it's very expensive. It's like $26,000 US per year. So it is very expensive treatment, comes with a lot of side effects. So what you really want to do is that you want to make sure that this particular patient has Alzheimer's disease. And the caveat here, the problem is that if the patient is already far too progressed in the dementia, it is too late. So you want to start the treatment when the disease is still mild, like not even dementia. There will be the window of opportunity, but it comes with a lot of side effects. So you want to make sure without like symptomatic presentation, you want to make sure someone has Alzheimer's disease before you start the treatment. Now FDA has approved 4 different imaging-based diagnosis for Alzheimer's disease, and there is one that involves spinal tap that can estimate this abnormal protein presence in the brain. And Health Canada approved one of them, so at least we have something. if the treatment is approved as well. However, and so in the States now, what is going on is that my colleagues in the nuclear medicine, they read like 5 patients a day, and then just get them approved for the Medicare coverage, because Medicare covers this treatment. I don't know if the Health Canada is going to be covered here or not. That's another debate. But at least in the States, Medicare covers it. So there is a huge demand in the diagnostic imaging for this patient population. However, the problem here that I see is that even if you have biologically confirmed Alzheimer's disease, it does not mean that you are going to progress to have a dementia in the next, let's say, 5 years. Some patients have all this beta amyloid and phosphorylated tau, which is the signature of the Alzheimer's disease, and live on like 15 years without any cognitive problems. There are some cases reports suggesting, and so in average, if you have those biological confirmation of Alzheimer's disease, and you have a little bit impaired in the cognition, like we call it mild cognitive impairment, about 1/3 of them, or maybe half of them, will progress to dementia within 5 years. So which means that half or 2/3 of those who have biological confirmation of Alzheimer's disease will not progress to dementia in the next 5 years. So we want to be able to tell who's going to progress to dementia and who's not. And that is one of the research topic that I'm interested in. And in order to do that, what we use is a neuroimaging, like brain scans. You're familiar with the MRI or positron emission tomography, as well as machine learning or AI, like artificial intelligence. So we use this technology to classify those patients who will progress to dementia versus who will not. Now, the accuracy is not exactly great yet. We say about 80% accuracy, which give me the idea to go back to Corey's comments that there is a lifestyle interventions that can slow down the disease progression. So maybe we can predict up to 80% confidence, but the remaining 20% may be up to those, lifestyle or, what happens afterward. So that is just not my hypothesis, that we have to talk later about how we can prove that hypothesis. So that is the current state, that we are working on this neuroimaging-based classification tool or prognostic tool. And my next question is, so there are a lot of research groups that are working on it. There are also companies that are working on this program. And so, but it is still, I wouldn't say it is not still there yet. So we need more investment and a lot of more researchers, AI researchers, to work on this project. And another way that we can use also this neuroimaging and AI is that we can also tell which type of intervention would be most beneficial for this particular patient. So it's more of a personalized medicine approach. So we tailor our treatment approach based on the AI interpretation of the neuroimaging data. So that's my second research topic that I'm interested in. Anyway, I guess I will stop there. Yeah.
Sounds good. Yeah, there'll be good time probably for discussion. You can ask some questions on some of the things that you've heard so far, and we'll continue on then with Dr. St. John and his thoughts.
Okay, well, thank you very much, and thanks for inviting me. I'll apologize in advance. The last time I had this many cameras on me was Reach for the Top in 1982 Minnedosa team, and I froze on air. And my mom videotaped it and gave it to my daughters when they were 17 and 15. So if I freeze, that's probably a bit of a PTSD. So I think if we step back, there are a few important general points. One is that aging comes with both good things and bad things. So health does tend to deteriorate with aging, but nevertheless, as Corey said, mental health in many ways improves, actually. And then if we step back and say dementia is clearly a major challenge facing both individuals, their families, and society. So dementia is the umbrella term for memory impairment that impairs function. So it's memory impairment that impairs your day-to-day functioning. Within that, there are multiple different causes, Alzheimer being the most common, but also vascular dementia and quite a few other less common things. And as Michelle alluded to, as long as Michelle and I have been around, there's been a lot of confusion about the epidemiology of dementia, partly because it's incredibly complicated. So there are multiple risk factors for dementia that operate over very long time horizons, often the course of our whole life. So that comes with good news and bad news. The bad news is that, I think personally, I think it's going to be a little bit hard to find a silver bullet that's going to detect all dementias, treat all dementias, and fix all dementias. The good news is that each little intervention you have to reduce risk pushes back the time of dementia. So I think in terms of the prevention, it's going to be a question of inches and inching forward and small little advances, each of which are incredibly important, both at an individual level and a societal level. The other related point is that many of these are interventions we can't undertake ourselves. So I think the initial title of this was How Can I Prevent Dementia? And I think we changed it to How Can We Prevent Dementia? Because many of the interventions are actually come at a societal level and a policy level, as well as an individual level. So there are things we can do to lower our own individual risk, but things like education, access to health care, access to non-polluted air are things that have to be done at a policy level to reduce everyone's risk, not a single person's risk. So I think while it's difficult to fully prevent dementia, I think it is a major improvement if we can push back the time of diagnosis of dementia and also reduce the symptoms related to dementia and reduce caregiving strain on people who are looking after people with dementia. When you look at the interventions, I would highly recommend people go to the Lancet Commission on Dementia. So the Lancet's a big medical journal, and they had a commission on dementia, on how to prevent it. And they focus on what you can do over the course of a life. So early in life, education is very important. So the highly educated a person is, the lower their risk of dementia. Not zero, but it does reduce the risk. Then in midlife, things like making sure hearing is good, access to hearing aids, attention to vascular risk factors, so making sure that diabetes is controlled, high blood pressure is controlled, depression, so making sure that depression is adequately assessed and treated is another midlife risk factor. And then as Corey alluded to, physical activity is actually emerging as quite an important midlife modifiable risk factor. And then things like avoiding smoking and avoiding excessive alcohol. And I was told to see a fair number of empty glasses around. Not to point any fingers, but I don't have to because you can actually see them. So, not to avoid alcohol entirely, but to try to minimize use. Those things will all push it back. And then in late life, addressing things like social isolation is critical. We often withdraw from life in late life, and we often withdraw from activities, and that's probably not such a great thing. And we often exclude older people from activities. And that goes for people with dementia as well. There's a tendency for people with dementia to withdraw from things, and it's actually important to try to stay as engaged as possible, obviously within limits of safety. And then one that's not quite fully fleshed out yet, but certainly is mentioned in the Lancet Commission is air pollution. So it does seem that air pollution may be, and again, this is fairly early, but there are several studies now that come out in the Lancet Commission showing that exposure to air pollution is not such a great thing. Now, importantly, everything I said is good for your general health. So it's not like you should be doing these things to prevent dementia. They also, prevent you from, again, they don't prevent you from dying, but they do delay death and they do delay disability. And then the final point of my 3 points is just to echo what Corey said. So Corey, Michelle and I are about the same vintage. And when all of these studies showing this U-shaped curve of happiness, so you start out quite satisfied with life and quite happy in your teenage years, and then things kind of bottom out somewhere between 45 to 55 in terms of happiness. And then afterwards, they increase. Now, when I started, it was all what's called cross-sectional research, and people thought it was just the time the baby boom were about 45 to 50. And so I guess by way of disclosure, I'm a Generation X. So a lot of people in my generation thought it was just the baby boom being baby boomers, and not too resilient. But now that the research has gone on for 30 or more years, it's pretty clear that life satisfaction and happiness actually increase up until at least about 75 and probably stabilize after that. Again, like Corey's saying, we don't know why, but despite all of the challenges and despite all of the issues with aging, people become more and more satisfied with life. And one of the more surprising things was in the Canadian Longitudinal Study on Aging, which is a large national study that's going on, was the COVID response. And I think everybody was expecting older adults to become more depressed during the COVID epidemic, which happened. But interestingly, the effect on mental health was much less in the older population than it was in the now younger population, being 55 to 65. So in fact, while COVID was terrible for mental health, no questions, it actually was the middle-aged people suffered more than the very old people. So it's not, again, clear why, but I think as we age, we can look forward to being a bit happier and more content, and our life satisfaction increasing, despite all the factors facing us.
Okay, great. Thank you, everyone, for your opening thoughts. Lots of opportunities now to hear questions, comments from audience members. Just a reminder that in asking questions, we ask that you don't divulge personal information or personal information of others. And also a reminder for those who are watching on YouTube, you could also ask questions. If we don't get a chance to get to your questions this evening, those questions will be sent on to our panelists this evening. So I think we have a question out there. So go ahead.
Hello everyone. So this is actually a two-part question. The first one is, lifestyle has been mentioned a lot in the opening remarks. So I'm curious to know how much of the Western or globalized lifestyle is promoting to the, let's say, rate of this disease. Because, for instance, I know of certain, let's say, experts, Dr. Bickman, for instance, who says that Alzheimer could be considered like a type 3 diabetes that is tightly linked to insulin resistance and type 2 diabetes itself. So how much of this lifestyle component can explain the onset of the disease? And the other part of the question is, knowing how important lifestyle is, how can we as a society kind of enforce or promote greater awareness of following these mandates for a better lifestyle?
Yeah, so one, we like to think that epidemiology is certain and settled, and it's not. So epidemiology and our understanding diseases and disease processes evolves over time, and our understanding evolves over time. And with dementia, the further along you go in the studies of causation, the more complicated it becomes. So it's a bit hard to tease out how much is due to lifestyle, how much of dementia prevalence and incidence is due to lifestyle, and how much is due to some of the other things. It gets further complicated because the things that putatively prevent dementia, and I believe they do, also prevent dying. So it's a bit analytically complicated to study because your risk factor predicts not being in the study, essentially, as well as perhaps being protective. So I think the answer is we really don't know how much yet, but clearly some of it. If you look at the Lancet report, collectively, hypertension, diabetes, larger size, and physical activity account for maybe 20% cumulatively, maybe, but again, that's a very rough estimate. So I think addressing those things is important. How you do it, I think, is interesting, and I see people who've done public health here and are more aware of that than I am. But, raise your hand if you think exercise is good for you. Yeah. The question is, how do we encourage people to do it? 2, how do we have a society that allows it, right? So if you're working 2 or 3 jobs, you're running around like a headless chicken all day, it's difficult to actually have exercise, and society lose track of that. We're talking about an aging society is the byproduct of hundreds of years of reasonable public policy. And again, prior to COVID, we had Canada, amongst other OECD countries, was remarkably healthy compared to historical or other contexts. I think things, though, we assume that's a given, and we assume that we will just keep getting healthier. And I think the last 10 years have been a bit of a wake-up call, where the last, there has been an increase in income inequality, an increase in poverty, an increase in mental health issues. And then, of course, COVID came along. So I think in the long sweep, we're very healthy, but I think if we look a long enough lens, it's actually pretty good. But I think the last few years have been rough.
Okay, I think we have a question.
Incidentally, this is also a debate within gerontology, right? So there are people who argue we're going to cure everything and we're all going to live to 1,000. So there are people in Silicon Valley who do say that. Come to my clinic, and the moderate people would be the people kind of in my camp, which would say that historically we've gotten healthier and healthier slowly and steadily. There aren't going to be miracles, but we're going to slowly advance. And then there's a third camp that says exactly what Corey has said, that we've gotten more stressed, we've created more inequality, we've gotten larger rates of high body mass index have increased, and we're going to become less healthy. So it's not like Corey and I are, we're both within the mainstream of gerontology.
Okay, and we'll maybe get back to, I'd like to have a conversation, if we can, later about like incidence and prevalence rates and what that means societally, but we will go to the back of the room with the person with the mic.
Ageism seems to be increasingly prevalent in our society. Once you get a certain age, there is less likelihood that you might be invited to participate in, say, a corporate activity or societal activity. The result is that this can increase mental health risks and so on. The question is, how do we, as a society, combat ageism?
Okay, I can maybe. I'm not a panelist, but this is an area that I'm doing lots of work around ageism. One, I think, and we've been doing some work on this, Dr. McKenzie and I, is that we have to build awareness about ageism, because a lot of people, including older people, don't think ageism really exists or affects them. And we actually have a program to try and, one, build awareness about that kind of societal ageism that exists, but also that internalized ageism. So older people themselves become ageist against other older people as well as themselves, and think that they're kind of lesser than because of their age, because of those societal messages. So first, we just have to build awareness, because society really doesn't think, one, that it necessarily exists or that it's that much of a problem. I think, over the course of the pandemic, I think there were many different cases that were brought up. So I think societally we are becoming more aware, but I don't think we're doing enough to fight back against it. And so, one of the things I'd like to do is to train older people to be advocates against ageism, because I think we need a lot more of that. We need the professionals who work in areas like equity, diversity, and inclusion to recognize that ageism is an issue and that we need to combat it in all sorts of different arenas, whether it's the workplace, which we know ageism is rife there, whether it's in the healthcare system. There's all sorts of places where ageism is causing problems. And I will say, even on that individual level, that internalized ageism, directly related to our topic for tonight, can have an impact on someone's cognition. And so they might have, lower cognition because they've internalized those ageist messages. They might become more isolated themselves because they don't think that they deserve to belong with others. And so there's all sorts of issues around that. I could talk longer, but I think I will leave it there. But thanks for bringing up that point.
Can I just say one more thing I wanted to add to what Michelle said, that this idea of internalized ageism, our tendency to internalize these negative messages. There's research now. There was a study done about 15 years ago. It was actually replicated recently, showing that internalized ageism has about a 7.5-year reduction in life expectancy for those older adults who have these internalized negative ideas about what aging is supposed to be about. Yeah. So we can understand that these sort of self-limiting attitudes are not healthy. They're limiting us from doing things that might otherwise keep us healthy and engaged. Yeah.
I'm interested in the medications that may be coming to market or should be coming to market at some point. I've heard you saying about how you can reduce your risk by healthy lifestyle changes, but you have to have a diagnosis of Alzheimer's before you be eligible for the trial or the medication. I'm wondering, it's a kind of a wiggly line, I think, between maintaining your health and why would anybody ever recognize Alzheimer's early enough to get you into a program where you would have medications to prevent it worsening? I'm not quite sure where the medical community is on that, on how to address that issue.
So first of all, the Health Canada has been reviewing this treatment since 2023. So it's been almost 2 years. So it will, in average, they take about 1 year and 10 months to approve a new drug. So I think it is going to come soon, one way or the other. And the reason why we need to know exactly why this patient has biological diagnosis of Alzheimer's disease is because the treatment there are mainly two reasons, in my opinion. The treatment is very, very expensive. It's $26,000 a year. And Medicare is covering that in the States. In Canada, we don't know what is going to happen, but I don't know. The rumor is that they are not going to cover it. Then there is going to be, inequality created to this possible treatment that some people may be afford to do it, but some people may not. So that's another issue. And another issue is that it comes with a lot of side effects. Because they have to. For now, the treatment is intravenous, and every 2 weeks you have to go to the hospital and get the intravenous injection, or like one over an hour. So it's a slow injection to the intravenous, and then there is also risk involved with the intravenous injection as well, and there is a brain bleeding, swelling. So side effect is not negligible. So we want to know for sure that this particular patient, in order to receive this treatment, we don't want to just, if this person will be living free of dementia in the next 20 years or even 10 years, do we want to treat them now for next 10 years, although, they will not have any dementia problem. So we should be able to, that's why we want to know the prognosis, not just the diagnosis. Diagnosis is easy now. You just have to get the brain scans or do the spinal tap, then we can confirm whether this patient has this abnormal protein that is characteristic of Alzheimer's disease. However, because this disease progression rate differs a lot by individual. So that's why prognosis becomes important in this field, which has been unfortunately neglected in the States. So in the States, what they do is as long as you have Alzheimer's disease biologically, you treat them. And and it comes with a lot of risk, like side effects, as well as it's very societally costly.
Dr. St. John, do you want to?
Yeah, I guess the new treatments only work for Alzheimer type dementia. They don't work for other types of dementia. And if you look, particularly in late life, in people I tend to see in their 80s, most dementia is actually mixed. There's a little bit of strokes, a little bit of head trauma, a little bit of this, that, and the other thing, not just pure Alzheimer's. So the new medications are only approved for pure Alzheimer's. So you first have to know, does the person have dementia, and then does they have an Alzheimer type dementia? And then there remains considerable controversy about the risk-benefit ratio across countries. So there remains, I would say, pretty heated discussion around whether it's worth, even at an individual level were it free, worth it or not. And then the other issue is the availability of diagnostic testing, infusion clinics, MRI scans, and I see a neurosurgeon in the audience who can acknowledge that MRIs are not, if you have to do 5 or 6 or 7 follow-up MRIs and people are waiting a year for a routine MRI, that has massive, massive, massive implications for resource use. So I think it'll be interesting to see where this field goes. And in America, they really have hit, as you're saying, they've hit the gas pedal, and it's approved, and they're starting to set up infusion clinics. Canada has been a bit more slow. Does that answer the question? Yeah. But I'll say it remains a controversial area.
So I was going to just add one other thing, that there is another method of diagnosis of dementia, and that is through neuropsychological testing, so that we have these options of neuroimaging or sending someone for memory testing, essentially, to get a diagnosis. Just wanted to add that in.
No, and I think that's an excellent point. It's a clinical diagnosis. Like, it's a clinical diagnosis with neuropsychology, occupational therapy physicians. The scans, the scans for amyloid are to tell if it's Alzheimer dementia or not. But the clinical diagnosis of dementia is a clinical diagnosis.
Yeah, so that is actually the tricky thing, because when they have, the treatment will be most beneficial if it is used before the patient has a full dementia. And the pre-dementia state is called MCI, mild cognitive impairment. It is extremely difficult to tell whether this person with the MCI have an MCI due to Alzheimer's disease, or MCI due to vascular dementia, MCI due to frontotemporal. It is very difficult to tell the difference. So that's where the neuroimaging can actually help. That with the machine learning technology, we can actually differentiate the different neurodegenerative disorders with, again, like 80% accuracy, not 100%, but it's better than nothing, I guess.
So my question relates to lifestyle, and it comes from without saying anything personal about myself, my sources are the highly scientifically reliable internet and YouTube. But they deal particularly with what I would describe as novelty, and that is trying new things in brain development at all stages in life, even to the point where you get good at something, you should do something else. I'm wondering if you'd like to comment on how important that is or not.
Yeah, I can start the discussion on this. We used to think back in the day that, new learning resulted in sort of neuronal changes to cells for young people and not for older people. And that we know that that's not the case now, that new learning, nerve growth, dendritic branching happens late in life as well. And it's one of the reasons that Phil mentioned education is really protective against dementia. So that's the sort of like educational piece. Learning new things is really good for cognition. Many of us don't do it as much as we get older. So there's this kind of focus on education in youth. But it's absolutely true that learning new things, putting yourself in novel situations is good for cognition at any point in the life steps. Your sources are good.
No, not Dr. Oz, I hope.
We talked about lifestyle, exercise, and all of those other factors. What is the relative weight of genetics in the clinical diagnosis as well, but even in improvement? Is it a definite issue that we have no capacity to do anything about?
So genetic risk is definitely there. There are certain genes that is known to increase the risk, like 4-fold or 5-fold, and there are some genes that hereditary dementia, right? If you have that gene, then you're going to have a dementia. But those are rare. More common one is that like ApoE or something like that. It increased the risk, but it's not. Those common risk factors are not like 100%. It just increased the risk. And another thing is that female have 2-fold more risk than male. So definitely genetics play a role there.
I just wanted to add that we also know that there's an interaction between genes and lifestyle, right? It's referred to as epigenetics, so that lifestyle environment will turn on certain genes or turn them off. So it's not an either or sort of a situation. It's genes plus lifestyle that's really critical.
I came across an area that I think would be very, very helpful for a lot of the retired people to know about. The clinical health psychology area in the McEwen building. You get assessed. It's a verbal, oral, partially written type recognition testing that your physician has to send you for. Mind you, it takes 4 to 6 months to get in. And that's one thing I'd like to address, that more and more seniors are aware of the start of being more and more forgetful, to the point where it gets scary. And it's good to have an assessment made. And I'm hoping, because it takes so long to get in there, that number one, they're training more people to do those type of tests. Even if it's specialized nurses, they follow a certain booklet of testing. I was told this is what was, highly recommended by, all the professionals, that this is the best test to follow. So once I was tested there, and I'm not, afraid to say, it was just very mild cognitive impairment. But my mother had Alzheimer's and my grandmother had Alzheimer's. So I had gotten a brain scan, and it just came back normal. Do they look for things like that when you are sent for the brain scan? I'm assuming that the technologists are well enough knowledgeable in the knowledge of the latest research of what to look for in those areas. So I'm taking that as a yes, right? That, or do you have to go to the research department? If there's something questionable, do they pass it on and say, this looks questionable, what do you think? Or
Current standard, as far as, and I'm not a clinician, but I work with the radiologist. So the current standard of brain scans for dementia diagnosis is using, at least in Manitoba, we use this positron emission tomography with glucose, the fluorodeoxyglucose. So that is typically read by nuclear medicine physicians without the aid of AI yet. So it is because it is not really approved yet. Those research grade interpretation is not really approved yet.
so that is coming. That is coming in the future. That will be integrated.
I'm pretty sure it will
more and
come, yeah.
more?
Yeah.
Okay, that's good to know. Hopefully.
Hopefully.
But this is the point of going to for this testing. They provided a Zoom, all comprehensive 10-week, once a week, and it was nice because it was in Zoom. You didn't have to leave your home, and they asked a certain group of people if they wanted to participate. And the really important thing, I'm a professional, so we know about. Most everybody knows about, yes, the exercise and good health. I mean, this is nothing new, but you sort of need this all put together in a proper package. We had handouts. It was explained. They went, and it was a Dr. Colleen Milliken and a Dr. Leslie Colvin, both in that field. You probably know of them. This was excellent. I needed that kickstart to pull it all together.
Sure, that's great. I mean,
excellent.
maybe I could get the panelists to say a few words. I think it's a good opportunity to talk about like what are symptoms. I think there's a lot of people think that they are having symptoms of dementia and they may or may not be. Maybe we could say a few words about what are actual signs and symptoms of dementia. What about screening? Should everybody get screened? Maybe you could say a few words.
Yeah. So dementia by definition is cognitive, like memory loss and other cognitive domains. So there has to be memory plus something else, visuospatial or some other cognitive function that's progressive. So it has to change over time and get worse. And it has to impair function. So it has to impair day-to-day activities. And it can't be due to something else. So it can't be due to what's called a delirium, like an acute illness or something like that. The onset is very insidious. So it tends to start with just forgetting day-to-day things that often normal people forget, right? So it often starts with quite a bit of overlap with not even normal aging, but just normal human, like where did I leave my keys this morning? Or why aren't my keys where I left them? That type of thing. And then it tends to progress to impair more sort of what we call high level instrumental activities of daily living. So things like, depending on your job, your work, or things like your banking or your finances, then it tends to progress on to impair other ADLs, activities of daily living. So it's actually quite difficult to pinpoint the exact onset. When somebody crosses the line from normal cognition to what's called mild cognitive impairment. So mild cognitive impairment, or MCI, is cognitive impairment that does not progress or does not impair function. So everybody with dementia has gone through a phase of MCI, but not everyone who has MCI goes on to get dementia, if that makes sense. So mild cognitive impairment is a risk state for going on, but it doesn't mean that you will go on. It's only when you start to see functional impairment that continues to decline that you can say it's dementia. So the things to look for would be those things. screening. So everyone should have what we call high index of clinical suspicion. So everyone should be concerned about memory if they notice changes, or if families start complaining about changes. That would be something that's not screening, that would be just good routine care. Epidemiologically, screening means you walk around the city and test everybody for their memory. And that is not recommended. So everybody should be suspicious and worried, but not everybody should go for memory testing just routinely. That was actually tried in England in 2011, for those of us old enough to remember. So the English NHS instituted a pay for performance for family doctors, where they paid family doctors to do memory testing. And it was a bit of a debacle, because all of a sudden there's all these people who weren't bothered, who weren't in trouble, who turned up positive on the tests, which has a lot of negative mental health consequences if you're inappropriately labeled with dementia. So nobody recommends screening, but everybody recommends that when somebody's worried, that should get assessed. Does that answer?
Yep, that's exactly what I was after. And that example of, you forget where your keys are. And I would, going back to the ageism piece, so one, not likely an indicator that you have cognitive impairment. And also I would recommend not saying, oh, I had a senior's moment, because that's one of those ageist things that lots of us do, and we should really stop doing that. So that's a simple thing that everyone in the room can do. Don't ever use the phrase, I had a senior's moment.
I just wanted to, you can say that. When I was doing my postdoctoral fellowship at Baycrest in Toronto, it's a geriatric care facility. We ran something called the Memory and Aging Program, which was a program for kind of normal, healthy older adults with memory concerns. And one of the reasons we ran that program is because everyone has memory problems and memory concerns. Everybody. It's just that when you're 20 and you lose your keys, you just kind of shrug it off. But when you're 80 and you lose your keys, now I've got Alzheimer's disease. And so we do want to sort of reassure folks that if you're having sort of occasional memory lapses or memory problems, especially sort of short-term memory, things that happen, recently or that you learned recently, that's probably fine. And if you're concerned about it, and especially if your family's concerned about it, if they're saying, hey, Mom, like I noticed something's kind of significantly changed, then you want to kind of progress to getting tested. But we want to kind of normalize age-related memory problems because episodic memory, which is that memory for new learning, starts going down in our early 20s. That's where it starts to decline, and it really kind of declines after 60, but that's also normal. Yeah. So hope that's reassuring.
Sorry.
Thank you for sharing your very interesting research. And I just had a question on if there's a standardized tool to determine what level of MCI is normal. And also, what are your thoughts on aluminum and Alzheimer's or dementia?
Okay, that's a whole can of worms, 2 cans of worms there. There are a multiplicity of cognitive assessment tools, all of which have different strengths and limitations. So there are some, like I'm assuming it's the ECOA clinic, where they do a whole battery of neuropsych testing, which is incredibly accurate, but is a bit of an endeavor, like hours of testing. That's the gold standard. So that would be at one extreme of extreme memory testing. Then there are tests that we use as clinicians at the bedside, which are imperfect, but probably better than nothing. And there is currently a fairly heated debate as to whether one should use what's called the mini mental state examination, which goes back to the 1975, actually. It's falling out of favor. One, it's old and people don't like it. Personally, I think it's fine. One of the concerns, and this is veering off into kind of crazy territory, but someone copywrote it and is demanding that everybody pay $10 to use it, so that if you live in an area, WHA, it's kind of a funny aside, the WHA lawyers said, don't worry about it unless we have to renegotiate NAFTA and copyright laws. And so here we are. Who'd have thought this would be happening? So that would be one. Then another bedside test is called the MOCA, or the Montreal Cognitive Assessment Test, which actually comes from Sherbrooke. And it's valid and reliable. Its advantage is it's a little bit better for high-end variability. And then there's also what's called the SLUMS, the St. Louis Mental Status exam. So there are a whole bunch of them. Each person has their favorite is the answer, I guess, that I would give. So each person has their own personal favorite, depending on how old they are, how comfortable they are with it, and their own change patterns. So for those of us that, you know, drive 20-year-old Camrys till they fall apart, the MMSE seems fine. That's one question. Does that answer that question? Yeah. So the question, nobody actually agrees, but all of them are actually not bad. Aluminum's an interesting one. So in my youth, aluminum was seen to be as a risk factor for dementia because there's aluminum. I guess with our terraforms, we should go back to calling it aluminium. Aluminum depositions in our brain. That was probably an artifact of the disease process and not the cause. So there were quite a few studies in the 90s, so the Canadian Study of Health and Aging being one of them, which looked at aluminum use, and at the time it was widely used in deodorants. So if any of you were participants in that study, there were like 1 million questions around what deodorant you used and how often you used it and that kind of thing. And I think the aluminum hypothesis is probably not true. It's probably not aluminum that causes it. It's probably a byproduct of the dementing process. Does that answer the question? Yeah.
That's great.
Yeah, if I can say one other thing about the MMSE, I agree with Phil. One of the problems with it is it's a test you score out of 30, and there's a sort of a cut point of 23. So 22 and lower indicates likely dementia. But of course, performance on that test is age related, and it's also education affected. So that if you're a physicist and you score 23, that's a problem, right? But if you're, if you grew up kind of working on the farm and you scored 23, that might be actually pretty good. So there are problems with this test. What happens, what's helpful is if you get that test and then you get it again, so your physician can kind of follow scores over time. That's quite helpful.
Yeah, and just to echo that, no test should be interpreted in isolation. So every test should be interpreted in the clinical context.
I just wanted to say thank you so much to the panel. This has just been most enjoyable, especially the comments about ageism after personally experiencing that in the workplace. So I just appreciate the being us learning how to be more advocates. I have two questions. First of all, we have a family history of vascular dementia and Alzheimer in my family, and I was just wondering if there's any preventative things that we can do, being, in your 50s and early 60s, to sort of just be more proactive on that, and if we're at higher risk. Second question is totally different, is are you more at risk for dementia and Alzheimer's if you've played high-level sports and received concussions? I have a son who has played many hockey, and that's just a bit of a concern. So.
May I? So yeah, traumatic brain injury definitely increases the risk of dementia. Repeated mild trauma is also a risk factor, so that there is something that we have to be aware of. Another one thing. So recently, we are still doing this clinical trial that involves some physical activity. I cannot disclose it too much because it's not published yet, but we score the likelihood of progressing to dementia with neuroimaging, right? And we had two different arms cohort. So one patients, well, this is a patient with a Parkinson's disease, but Parkinson's disease also are at risk, elevated risk of a dementia. So, but these patients don't have a dementia yet. So one cohort went through this novel treatment that also kind of used their kind of mental, cognitive computer game, and while they are walking on a treadmill. So it is both cardio as well as the brain. And the other control group that we thought that it would be interesting, the control group would be just doing simple walking. And both groups showed a decreased score in the dementia risk, almost same. So, it's physical activity for sure is important, but that's a one way. And then we can, of course, it is just brain imaging scans and telling you that you're at a lower risk. It does not, guarantee that you're not going to have a dementia, but at least it can lower the risk.
Yeah, I'll just maybe mention that we've talked a lot about Alzheimer's disease. You mentioned vascular dementia too. So that's a type of dementia that's caused by kind of larger or smaller strokes in the brain. And we used to think that it was vascular dementia that was sort of most amenable to these lifestyle changes. That if you stop smoking and eat healthier, get more sleep, all those kinds of things, that's going to help with vascular dementia, and it does. But what we know now is that it also helps with Alzheimer's disease, those lifestyle changes.
This question comes from Ben, who's watching online. Does spirituality, or a lack of it, affect dementia rates or trajectory?
Do we need to give disclosures about our religious background here? I noticed we didn't give disclosures. It's very difficult to disentangle the effect of religion from the social benefits of being in a group. So it's very hard to answer that question with any certainty. If you regularly attend church or a temple or something, there's a huge social impact. So it's very difficult to disentangle that from any spiritual or religious epidemiology. So wearing my epidemiologist hat, I would answer, we really don't know for sure. That's how I would answer it.
I mean, we do know that spirituality, in the two ways that Phil mentioned, is really good for mental health. And it's another reason why older adults have this benefit and that younger adults don't, because older adults are more likely to engage in practice, spiritual practice, than younger people. So we know it's good both for kind of the meaning making that people have, but also for the social connection that they get through their places of worship.
This is, can you hear me? Yes. Mini Mental in long-term care facilities. They ask the day, the year, so on. Most of those people are just sitting around staring out the window, nothing going on. They never know what day it is, and so that's automatically a downer. I used to give them.
Yeah, we all sort of lose track of the day when we're on vacation, don't we? It's the same kind of idea, yeah.
Well, and those of us that work in hospitals where there are orientation devices, the whiteboards, they're often wrong. So if you walk around the hospital into patients' rooms and it's often, March 21, and there's a McLean's from 10 years ago was another orientation device. So it's a good point. It's just general good care to have orientation aids. Yeah.
This has been a really informative discussion. It's really eye-opening. Wondering what is the clinical utility of the spinal fluid measurements and how accurate are they, and are they being used for prognostication?
Well, not in Canada. In the States, they approved this spinal tap assay, which estimates the abnormal protein level in the brain. And it turns out to be pretty accurate, like 80% to 90% accurate in predicting, because it's all connected. So and then it is approved method to confirm the biological diagnosis, at least in the States. I don't know if it is going to be the case in Canada, but we'll see.
Why wouldn't it be?
Yeah, so why wouldn't it be? I don't know. I mean, this.
Well, as you know, access to testing is not easy. The sensitivity and specificity isn't perfectly known yet. And third, it's not, I think with some of the imaging techniques may supplant the need for a spinal tap, which is, you know better than I do, quite unpleasant, depending who's doing it, I guess. So, I think right now it's not widely used. And then it doesn't influence treatment yet, although with some of the new drugs, it may. So it may start to become more common. And does that answer the question?
Yeah, and the CSF assay is also, it can induce some bacterial seeding and all this lumbar puncture. It has a certain risk.
Yeah, well,
for sure.
well
Yeah.
aware of the risks.
So, yeah. But, it's, and then it's also expensive too.
But it seems like it might be as accurate or more accurate than the neuroimaging test.
Oh, so for now, the way that they claim that CSF is useful is not, so the gold standard of those diagnoses on the postmortem examination. But the way that they get it approved is that they assume the brain scan as a gold standard. And then the prediction of the brain scan results from the CSF was up to like 90%. So it cannot, unless there is another postmortem studies to confirm it, it cannot supersede the accuracy of the brain scans.
Thank you very much for this wonderful presentation. And my name is Barbara. I work for the College of Medicine in the population health course. And when I was pursuing my PhD, I was looking about education for older adults as a source of health promotion. And we are saying here today how important is this opportunity for older adults. And when I was collecting data in 2017, I had to go outside of Winnipeg because there were no programs in both universities that would offer those type of opportunities for older adults. I was collecting data in Brazil, where I used to work, and in Regina. And I want to see, knowing that this decreases the cost of healthcare because older adults will be improving their health. This is shown in many research, including mine. Why not investing in more programs like this within university setting? I would like to hear perspectives about it.
Perhaps I should take that one on the age-friendly university front. So one, I think there are some educational opportunities. I think we have some great things going on in the city. So I don't think we need to kind of duplicate what's perhaps being done by other organizations. But I will say that there are opportunities for people, in fact, for people 65 and older, can take courses for free. There is free tuition in Manitoba for people who are 65 and older. We are trying to, as an age-friendly university, trying to make the process to actually sign up for courses easier. Right now, it's pretty labor-intensive and not very easy. So we are definitely working on that. We've had many conversations as an age-friendly university committee because, of course, as a university, we have hundreds of courses that, all of you in this room might be interested in taking, but we haven't done a lot to try and promote that, even though we do have free tuition. I'll mention that again, because we know that it's not that easy. So certainly I think we need to do a lot more, even societally, around lifelong learning. I think, there's been some big pushes even from people in extended education to say, there's all sorts of funding that goes into, post-secondary, like we're offering at the University of Manitoba, obviously our kindergarten to grade 12 education, but there's not a lot of funding for adult education, whether it's through extended education or it's for programming for older people. So I think really as a society, we do need to rethink education is not just something for people at the beginning of their lives. It is for people across their lives, particularly as people who are, more and more people are living into their hundreds, we need to be thinking about having these longer lives and going in and out of educational programs throughout our lives. So I think it's a really great point, and certainly that education piece has impacts on people's cognition. And so you're right, there are some good cost benefits to it. Besides the fact that it would allow for a lot more intergenerational interactions. Yep.
Can I just ask by show of hands, how many people are aware of this free tuition for 65 plus? Okay, that's not bad. I mean, we sort of expect a higher uptake in this crowd, but I think we do need to do a better job of advertising that too.
So my question is actually about education. What is it about education that helps with reducing the risk of dementia or other cognitive impairments? Because not everybody can access education, exactly like you said, funding. Some people can finish undergraduate degree. Like I am an international student, I paid 80 grand in undergrad, and I can't afford another 80 grand for master's. So what can I do if I don't pursue further education? Like,
I'll just start off and then maybe go to Corey or others. I mean, one, education doesn't have to be formal, so it doesn't have to be through a program. So there's lots of ways to learn that don't involve enrolling in a formal program. So, there's lots of ways out there. There's lots of online courses even that are free, but just reading, like there's lots of ways that learning can take place that doesn't have to be through programs, although I think programs would also be helpful. And I don't know if either of you want to, or anyone wants to say more about like, how does it, because I think that was the first part of your question, how does it actually impact physiologically or otherwise?
It's an excellent question, the answer to which is nobody knows. There are four kind of possible theories which are not mutually exclusive. So one is that it's not really protective, it's just you build what's called cognitive reserve. So the more education we have, the more, if you think about flying, if you're flying at 35,000 feet, you can lose a bit of altitude before you crash. So if you build up cognitive reserve through education, you start at a higher level, but you may lose altitude at the same rate. The second theory is that it's truly neuroprotective and that it increases the synaptic connections. So it actually slows down the rate of decline, not just your starting point. And then the third possibility, which is it's a surrogate of your social position or your socioeconomic status. So it may be not actually an education that's helpful, it's having a high-income, cognitively enhancing job that you like. And so it's just a surrogate of social position. And the fourth possibility is that those of us who take tests get good at it. And that's how we diagnose dementia. So we just are good at multiple guess questions and things like that. So it's just an artifact of the testing. So it could be any of those four things, and they're not mutually exclusive. But regardless of how it gets sliced, education, formal and informal, is very strongly protective against developing dementia, like quite strongly protective. That does beg the next question: is if you think my grandfather's education in the Interlake in 1904 was grade 4. My dad in the Depression, he went to university, but all of his class were grade 8. I'm postgraduate, and my daughters are more educated. Like, how much more at a public health level can we push the protective, effective education? Is an interesting policy question. But for us, being educated is a good thing.
I just want to mention there's also something about education in terms of like this kind of thirst for knowledge. The reason that you're all here tonight, this kind of speaks to sort of a general interest in learning new information. And that includes learning the kinds of things we're learning about tonight, about the importance of like new medications and procedures and lifestyle factors. So this is all sort of part and parcel of this sort of like curiosity, growth, learning things that are actually going to be helpful for you.
I guess I should ask something. I've had a lot of questions answered along the way, but I guess maybe I'm just going to process, from what an overview, as I understand it, it doesn't really matter what type of cognitive impairment you have in terms of whether it's actually Alzheimer's or multi-infarct or whatever, like my dad had. And I mean, there's different types. There's early onset, I guess, is a class on its own, because those people then you know exactly that it is Alzheimer's and you know it's going to progress. But so it seems that really it doesn't matter what kind of impairment is happening. It's important, I guess, for some of these drug companies that are pushing types of medication south of the border, and they really want to have these interventions. But really the focus is on what, I can't remember your name, but the psychologist, the clinical psychologist has said about those 4 factors or 5 factors of lifestyle and community involvement. So am I wrong in that the psychologist, the clinical psychologist has said about those 4 factors or 5 factors of lifestyle and community involvement? So am I wrong in that it
progress more rapidly than others, and that's important to know. So for instance, dementia of the Lewy body type, it progresses quite rapidly. Even if it's not treatable medically, it's very important for families to know what to look for. So some like frontotemporal dementia do matter because they have very different symptom profiles and very different symptoms to look for. And again, even if it's not treatable, people need to know what to expect and what's coming. So the answer to that is, does the subtype depend? Sometimes it does, sometimes it doesn't. And then the other thing to think about is in very late life, so the people I tend to see over 85, most dementia is actually mixed. So it's not pure Alzheimer, it's not pure vascular, it's a mixture of different things. And in that population, the exact type probably doesn't matter very much. But in some people, it really does. Like if Lewy body dementia, you need to look for other symptoms of Parkinson's and things like that. So the answer is it might depend in some people and it might not depend in some people. And then the other thing to keep in mind is if these Alzheimer medications do prove to be useful and do prove to be available, the subtype really does matter because it really only works for pure Alzheimer dementia. And that's where things like LPs, lumbar punctures, and the different imaging does make a difference. So I guess then my answer as a clinician is it all depends on the person. Sometimes the exact diagnosis matters. A lot of the time it actually doesn't matter much.
And if I may just add a few things. So for now, yeah, I agree and everything, but in the future, because what I'm trying to do is to use the neuroimaging analysis to identify which of the brain region needs to be targeted by, I use a non-invasive brain stimulation to increase cognition or suppress the mental health issues. So that kind of a neuroimaging can help us to identify which of the brain region is problematic. And then that differs across individual. For example, one of the studies that I'm doing is Parkinson's disease with the dementia. And if I look at the image, some people have, although they both have a same Parkinson's disease with the dementia, actually they are in the state of a mild cognitive impairment, but they were eventually developed the dementia. And then some people have some like a decreased metabolism in this region, and some people have a decreased metabolism in this region. Everybody has a different brain pattern. So if we are going to use a brain stimulation to enhance their cognitive function, that targeting needs to be adjusted according to the individual pattern. So in that note, that neuroimaging or differential diagnosis and interpretation will be useful. It will be actually necessary, although it is not available yet. But yeah.
Okay, I think there's one more question Pardon, one more or two more? Okay, we're three more. Okay, we're going overtime. Okay, good.
Okay, thanks. I'll kind of bring it full circle, and I appreciate the panel's time and lots of great questions. My question is, our healthcare system does, I think, a pretty good job in acute illness. So if you come into the hospital with a heart attack or a bowel obstruction, you're seen quickly, you get treated quickly, and you're out the door quickly. We don't do so well with chronic diseases like diabetes, congestive heart failure, COPD, chronic mental health conditions, these kinds of things. And I'm wondering, as a society, how do we incentivize people to take personal responsibility and accountability for their health? Because many of the chronic disease conditions, genetics play a factor, but also lifestyle plays a big factor in those. And I'm curious from you guys' perspective on the panel, how do we start to, as a society, incentivize healthier living? And do people get a health spending account and they get a certain number of points that they, there's all kinds of ideas out there, but I'm kind of curious from your perspective, how do we go about that? Because, cognition, by the time somebody's diagnosed with Alzheimer's, vascular dementia, it's 10, 20 years prior to that where the damage is actually being done. It's not at the time of diagnosis. And so, again, how do we start to incentivize a different responsibility for our health outcomes?
Okay, I think there were lots of things in there. I'll maybe start us off and then go to other panelists. I mean, your first point about our healthcare system is kind of focused on acute rather than chronic. There's a really good report out there from the World Health Organization that really digs into that a lot and talks about how for aging societies, we need to do a lot better in dealing with people's health over time and these chronic conditions. And so I would really direct you to that. I don't think we have a lot of time to go into all the details that are in there, but really thinking about with an aging society, we need to be rethinking our healthcare system and how we deal with these chronic conditions. In terms of the personal responsibility piece, I think there's also a lot in that document and the Global Strategy and Action Plan on aging and health to not just focus on the individual, because one, it's no guarantee that you're going to prevent things. There's no absolutes with any of these kind of preventative techniques. And there's also all sorts of societal issues. I'll just bring up one. My background is in kinesiology. So physical activity is very important. Not everybody has the time, the money to go to a gym. I don't even do that myself. I walk around the community. I take the bus. But you know what? March is a horrible month. I always say I don't want to be here in March because it's treacherous. It's treacherous to get around by walking. So here we've got the most popular form of physical activity is walking. And I would probably tell a lot of older people not to do it in March unless they can go somewhere inside, which again, transportation is a barrier for a lot of people in getting to exercise programs. So I think we need to do a lot more societally to really enable people to be able to take advantage of some of these kind of health promoting behaviors that we don't do. We put a lot of emphasis on individuals and not necessarily doing enough as a society to enable people.
As my daughter says, same.
Hi, thank you so much for this very informative session. So a quick question about the treatment for Alzheimer's. We kind of touched base about identifying the symptoms, the diagnostic process, preventative and protective factors. And we kind of touched base on enrolling those subjects or patients into the clinical trials where they're able to receive treatment, but we never talked about what medication are we talking about? Like, are we talking about like the old cholinesterase inhibitors, anxiolytics, the new monoclonal antibodies, or like a combination of all those? And amongst those, which one proven to be more reliable or promising? What are the effects and side effects? If you can just touch base on that very quick. Thank you. I'm more interested about medications.
Okay, I'm kind of smiling because you said old cholinesterase inhibitors, and I remember when they came out. So, Yeah, so I think the key thing is actually that there are a lot of non-pharmacologic approaches that are critically important, and we tend to emphasize the new or existing drug treatments. And I think it is exceptionally important to remember that you need a holistic approach. So, first you need to support families and caregivers. There are interventions not just to educate families and caregivers, but to actually teach them how to communicate with people with memory problems, because many of the ways that we normally communicate with people don't really work very well in somebody with a cognitive impairment. So things like trying to change the subject is often useful, trying to avoid contradicting people, trying to avoid pointing out deficits. And when you start saying this out loud, it's kind of Canada's foreign policy in the Trump era. Don't pick fights, don't argue, don't try to explain things, don't try to use reason, just try to go along with things up to a point, obviously. And then 3, we need to have actual supports for families. Home care in Manitoba, it sounds surprising to say, but is amongst the most extensive in Canada. So it's inadequate, I think, but it is more extensive than other places. Personally, I think what it lacks is flexibility. So it's very task-oriented, not person-oriented. So I think we need to have adequate home care and flexible home care. We have to have access to primary care, which is often lacking, and we have to have access to specialist care, which is lacking. So I think those are actually way more important than medications. So there are medications that do not alter the progression of disease, but they slow the progression down. So they don't alter the pathology, but they do slow things down. Again, the effect size is really quite small, actually, and there are side effects in terms of slower heart rate, gastrointestinal side effects, nausea and vomiting. But that is one drug that's been around since 1997. Are the cholinesterase inhibitors, and it is a useful tool. And then there are all the new drugs that are just been studied and just been released in the US, but not in Canada yet, no. So there's aducanumab, lecanemab, and those drugs. Again, they have been approved in Europe as well. Canada's approval process is slower. But again, even in areas where they've been approved, they're only approved for a narrow spectrum of people who have true Alzheimer's disease. And there are side effects like brain swelling and small hemorrhages. And then the cost is $27,000 US, but also the cost of neuroimaging, follow-up MRI scans, infusion clinics. So the cost is quite high. So those are the new drugs that have just been approved. Does that answer the question?
Yeah, I was hoping to know if the monoclonal antibody drugs are available. Yeah, I was hoping just
they're
to
not
know if
available
they're
in Canada yet.
not even in clinical trials at this point.
No, not
okay.
no.
I see. Thank you so much.
Yeah, but they are under review at HPP.
I see. Thank you so much.
Yeah.
Thank you. Quick question. Wanted to know about, is there any relation to Alzheimer's and dementia related to epilepsy? Like, if a person has been diagnosed from epilepsy, will that increase the chances of getting Alzheimer's or dementia?
Yeah, epilepsy increases the risk of dementia. We actually did some studies with epilepsy patients. We took the brain scans, and then some of those patients, although they were not really have a dementia yet, has showed some elevated risk of.
And that, if there are any chances of doing that.
So that's a complicated question. We don't know because epilepsy itself can cause the brain damage, right? And then it also most common part that it is affected is the is inferior temporal regions, hippocampus, which is also the target area of the Alzheimer's disease. So it targets common brain areas, and maybe that's why we see similar pattern of glucose metabolism in the brain in the epilepsy patients. I don't think it is yet known whether this new monoclonal antibodies would work in epilepsy patients. I don't think that has been studied. So it remains to be seen. Yeah. But for now, I would say you have to address the epilepsy to at least minimize the damage.
Thank you. Thank you.
Thank you very much. We were in overtime, so I'm turning it to Michelle to close the event. And thank you all for your amazing questions and coming out.
Yes, thank you very much, everyone. Thank you to the panelists and doing such a great job in introducing the topic as well as answering all the questions. We've covered a lot of ground this evening. I know I've learned a lot. I hope all of you have learned a lot. I would say if you want to learn more about Alzheimer's and other dementias, the Alzheimer's Society of Manitoba has lots of great information on their website about the conditions, treatment, prevention. They also have lots of programs and services, so I'd really encourage you to check them out. And I'd also say we've got some handouts up here about the Center on Aging, about Age Friendly University. So if you want to learn more about the things that we do as a center, we have lots of events that people are welcome to attend. And with that, I think I will close things out, and I think we'll stick around for a few minutes if people have some additional questions, but probably not all night long. It seems like we could keep going all night, but for a few more minutes. And thank you to the audience on YouTube as well for sticking with us. Have a good night, everyone.